Hi guys, welcome again to Intellect Medicos, where learning is made easy. I'm Dr. Chirag Madan, working as an intensivist ICU consultant at Apollo Hospital, New Delhi. This video is actually based on the request from all of you guys, from my juniors, from my colleagues, and this is all about reading and interpreting X-rays in a simplified manner. And in this video I have discussed around 25 X-rays, and that too starting from the basics, which you need to know. So do watch this video till the end to become a chest X-ray expert. So let's begin. Before you start reading or interpreting the X-ray, you need to know which is the right and the left side. In this X-ray, this is the right side and this one is the left side. And this is usually marked on the X-rays. A good way to remember is that you imagine that the patient is always facing towards you. This is true for both PA and AP films. Now, I'll tell you the structures which are normally seen on chest X-ray. I'll just mark and name the structures. I'll discuss in detail in the later part of this video. So this is a trachea, this is a carina, right bronchus, and this one is left bronchus. This is divided into right and the left bronchus. Then this is the lung field. This one is the clavicle. Then this is aortic knuckle. This is the hilum. Over here is the heart. This one is a diaphragm, the right hemidiaphragm. These are the ribs. And this one, as you can see below the left hemidiaphragm, is a gastric bubble. Now this X-ray looks like a perfect X-ray, right? And before moving further, you need to check the patient detail. This is very important, and it is always mentioned on the X-ray. Now the name is Chirag Madan. Oh, I know this guy. Oh, okay, that's me. Okay, no issues. So check the name, the age of the patient, the unique ID number, and the date on which it is taken. Next is to assess the quality of the image. It can be remembered by a mnemonic, RIPE, where R stands for rotation, so as to see whether the film is rotated or not. The spinous processes should lie halfway between the medial ends of the clavicle. That means in between the medial ends of the clavicle. If the patient is rotated, then interpretation of the X-ray becomes difficult. Firstly, it may be difficult to know if the trachea is deviated to one side by a disease process, and it also becomes difficult to comment actually upon the heart size. And the changes in the lung density due to asymmetry of the overlying soft tissue may be incorrectly interpreted as lung disease. So now let's see what happens to the heart size with respect to the rotation. So this is a person standing over here, and there is a film in the front, and this is a normal. The rays are coming from the back, so this is most likely a PA film. And if the patient is rotated towards the left, let's see the second image. Second image shows patient is rotated towards the left. So as you can see, the X-ray beams are going like this, and heart size looks greater or magnified or exaggerated. Whereas if you see the third image, the patient is rotated towards the right. In this, the true size of the heart may be underestimated. Now next in RIPE is inspiration. Ideally, chest X-ray should be done in inspiratory phase. If the X-ray taken during a good inspiratory effort, diaphragm should be intersected by 5 to 6 anterior ribs or 8 to 10 posterior ribs in the mid-clavicular line. Less is a sign of incomplete inspiration. Whereas if more than 7 anterior ribs, then it suggests hyperinflation. Now let's count in this X-ray, X-ray number 1. So these are the posterior ribs, whereas these one are anterior one. Let's count the anterior ones. This is first, second, and third. So there are 3 anterior ribs intersecting the diaphragm in mid-clavicular area. That means this is either an expiratory film or poor inspiratory effort. Also, heart appears bigger and there seems to be consolidation on left base. Now let's see the next X-ray. So the number of anterior ribs in this X-ray are, you can calculate, 1, this one is second, then third, then fourth, fifth and sixth. Heart seems to be normal and there is no consolidation at the bases. Now don't get surprised, my friends. These two x-rays are of a same patient. One in the expiratory phase, the first one, and the second one in the inspiratory phase. Now why such a big difference? First of all, diaphragm pulls the undersurface of the heart down during a good inspiratory effort, which is absent in expiratory phase. So heart appears bigger in transverse diameter. Whereas the second reason is the failure to distend the lungs fully can cause crowding of vessels at the lung bases. And the resultant appearance is this can be misleaded with a lung infection or collapse. So that is the reason we always should look for a inspiratory film. Next comes the P in RIPE, which stands for projection, either AP or PA view. Let's understand the concept. PA stands for postero-anterior view. In this, as you can see on this diagram, the X-rays enter through the back, that is the posterior of the patient, to a film cassette which is located in the front anteriorly of the patient, as you can see in this diagram. On the other hand, if we talk about AP, which stands for anteroposterior, in this imaging the beam shoots from the front, that is anterior of the patient, and hits the plate located behind the patient, that is posteriorly. This is done in patients who are frail, who are not able to stand, or who are admitted in ICUs. Radiographers will often label a chest X-ray as either PA or AP. So you can see on the X-ray, if the image is not labeled, let's say it's not labeled, then you consider it as PA. That is a PA view, right? If you are not sure, then look at the medial edges of each scapula. In order to take a PA view, the patient places his or her arms around the side of a detector plate or stands with hands on the hip, as you can see in this diagram. This ensures the scapula are rotated laterally and no longer they overlap the lungs. Now let's see the PA view X-ray. So in this X-ray, you can see the edges of the scapula are retracted laterally with only a small portion projected over each lung, and heart size or cardiothoracic ratio is in normal range. Whereas in an AP view, patient is lying down, so scapulae, they are not retracted. In this particular X-ray, you can see the scapulae are not retracted laterally and they are projected over each lung. Also, the heart appears large in an AP view. This seems very confusing, right? No worries, I'll explain the concept. Now see this diagram. The upper diagram shows an AP projection. Heart appears larger because the heart is relatively away from the detector, and also because the X-ray beam is more divergent as the source is nearer the patient. Whereas if you see the lower diagram, it shows a conventional PA projection. The apparent heart size is nearer to the real size, as the heart is relatively nearer the detector. Magnification of heart is also minimized by use of narrow beam produced by increased distance between the source and the patient, which is normally 6 feet or 180 centimeters in PA projection. As you can see in this diagram, the X-ray beams are coming from a far away distance, right? And now you will be amazed and surprised to know that these two, the previous two X-rays which we discussed, are of a same patient. One is in the PA view and the other in a AP. So the most important, the most ideal and the most optimal view is the PA view. Next comes E in the right, that is exposure. With proper exposure, the spine should be faintly visible behind the heart, as you can see in this X-ray. Now, whenever you need to read or interpret an X-ray, you need a systematic approach, right? Either it can be remembered by a mnemonic A, B, C, D, E, or you can read the X-ray from inwards to the outwards. In this video, I'm talking about a mnemonic so as to remember how to read an X-ray. Now starting with the A of ABCDE mnemonic. A stands for airway, that is the trachea, the carina and the bronchus. So look for any kind of tracheal deviation. The trachea is normally located centrally or deviated very slightly to the right, and before commenting on tracheal deviation you need to make sure that there should be no rotation. Now in this X-ray you can see trachea is pushed to the other side. So this X-ray is of massive pleural effusion, that is the collection of fluid in the pleural cavity on the left side, which has pushed the trachea on the other side. Now see this X-ray, the next one. Now can you see the difference on the right and the left side? The right side lung fields is more black and there are no vascular markings seen. So this blackening is actually due to air collected in the pleura on the right side, which is called as pneumothorax, which has actually pushed the trachea on the left side, that is another side, opposite side. Now look at this X-ray, X-ray number 8. As you can see, trachea is deviated to the right side, but there is no pleural effusion or pneumothorax on the left side as we discussed in the previous two X-rays. So this has happened because of the collapse of lung on the right side. So that means there is a collapse which has pulled the trachea on that side. So there is a collapse on the right side. Next to look for is the breathing or the lung fields, and B also stands for bones. So A, airway, B, either breathing or the bones. So first talking about the breathing. Air on X-ray looks black, but if in the lung fields you see white shadows or opacities, then that suggests there is a pathology in the lung. Let's see this X-ray. Now you can see whitishness or haziness in the right middle and lower lobe, and also on the left lower lobe. So this goes in favor of consolidation, that is pneumonia, which is actually replacement of alveolar air by fluid or cell, pus or any other material. But before commenting it as consolidation, you need to see the clinical picture as well. Any presence of fever or signs of infection, right? And also you need to compare with the previous X-rays if available. Coming on to the next X-ray, X-ray number 10. Now you can see a discrete area of whitishness on left side. This is a solitary mass. Again, you have to correlate with the clinical history of the patient, and to confirm you need a biopsy. Coming on to the next one, X-ray 11. In this particular X-ray, you can see multiple round white discrete areas on both the lung fields. So this is lung metastasis. X-ray number 12. In this X-ray, you can see white rim encircling the black air on the left side. This is like a hole in the lung called as cavitatory lesion, and there are various causes for that. It could be abscess, neoplasm, necrotizing pneumonia. Coming on to the next one. Now this is a very important X-ray as far as clinically and if you talk about the MCQs. In this particular X-ray, you can see ill-defined opacities or shadows in bilateral perihilar area extending laterally, which is suggestive of pulmonary edema, and this is most likely due to left heart failure. This perihilar shadow appearance, it is actually called as bat's wing appearance. Very, very important for all your MCQ or your medical examination. So coming on to the next one. Now this patient is admitted in ICU with complaints of aspiration 2 days back, currently on 80% oxygen support from the ventilator, and previous X-ray was normal. Cardiac status is also normal. So what is the most likely diagnosis? Now you see bilateral infiltrates on X-ray, acute in onset, that is less than 7 days, decreased PF ratio, that is decreased PaO2 by FiO2. I mean there is decreased oxygenation as suggested by 80% oxygen support, that too from a ventilator, and there is no cardiac issue. So this is a classical picture of ARDS, acute respiratory distress syndrome. Very, very, very important. whenever you are working in ICU setup or in your wards, or obviously this is not possible in your ward, in HDU area, in your ICUs, and very important again for your MCQs. Well, I think you got the point now. Clinical history is very, very, very important to diagnose a patient. Moving further, if we talk about pleura, we have already seen pleural effusion and pneumothorax. One more thing I need to tell you is, whenever we are talking about pleural effusion, we see the CP angle, that is a costophrenic angle. If it is blunted, that is suggestive of pleural effusion. Coming on to the next one. Now in this X-ray, the arrow is pointing towards a thin black rim without vascular marking, suggesting pneumothorax. And you can also see the air fluid levels on the right side. So this X-ray is hydropneumothorax, which is most commonly seen in road traffic accident cases. So this was all about the breathing part. Second B is bones. Now look for any kind of bony fractures. In this X-ray, you can see a left clavicular fracture. Now in this X-ray, see the normal ribs contour on the right side, whereas there are multiple rib fractures on the left side. Till now we have covered A and B of the mnemonic ABCDE. Now coming on to the next one, that is the C, which stands for cardiac. Let's see this next X-ray, X-ray number 18. The right atrium makes up the right heart border, whereas the left ventricle makes up the most of the left heart border. Now the next important thing is assessment of the heart size. It is assessed by the cardiothoracic ratio, that is CTR, which is cardiac width divided by thoracic width, and it should be actually less than 0.5, or you can say less than 50%. But mind you, cardiac size is always assessed in a PA view, not in the AP, and you know the reason, we have discussed in the previous part of this video. Coming on to the next one. This X-ray shows high cardiothoracic ratio, that is high CT ratio, that suggests cardiomegaly, as you can see on the X-ray. Now coming on to the next one, that is D, diaphragm. Normally in healthy individuals, the right side of the diaphragm, that is right hemidiaphragm, is situated superior or higher than the left one, and below the left hemidiaphragm you can see this A shadow, which is gastric bubble. But if there is a gas beneath or below the right hemidiaphragm, that is alarming situation, and that suggests perforation. That is actually pneumoperitoneum, that is the air in the peritoneum. So pneumoperitoneum, right? Now see the X-ray. So there is the air under the right hemidiaphragm. So this is a pneumoperitoneum. Now the last is E, which is everything else which is left. I mean the lines, the catheters, everything else, right? So this X-ray, you can see nasogastric tube in situ, so NG tube or a Ryle's tube. In the next one, you can see a white line in the trachea, which is actually due to endotracheal tube in situ. So there is a ET tube. So next one, in this you can see there is a right IJV central catheter or a central line. Look in this X-ray, can you see anything abnormal? Yeah, so there are sternotomy wires, mostly after the cardiac surgery, CABG. So there are sternotomy wires. Then in this one, can you see something unusual? Yeah, so there is a pacemaker over here. Coming on to the last one, can you see any abnormality in this X-ray? Yeah, so this arrow is pointing towards prosthetic mitral valve. So this is all about the basics of chest X-ray, which you should be knowing as a medico, as a nursing staff or a paramedical staff. So we all who are working in the hospital setup, we should be knowing about this chest X-ray, right? This is a basic thing. And if you like the content of this video, do hit the like button and share with your friends, your colleagues who needs this, who want to understand and know the basics of chest X-ray. And also do not forget to subscribe the channel to get the updates about our new videos. So thank you so much guys. Take care. Bye bye.